So now I'd like to introduce Dr. Charles Prestigiacomo from the University Hospital at the University of Medicine and Dentistry in Newark, New Jersey, where he is the director of the cerebrovascular and endovascular neurosurgery group. And he'll show you a case of an aneurysm.
Thank you.
Dr. Prestigiacomo.
Thank you. Good evening, ladies and gentlemen. And once again, thank you for the opportunity to present here. I'd like to thank Volume Interactions for the wonderful work that they've been doing on this software and hardware. I believe that virtual reality brings you one step closer to the operating room without actually crossing that threshold. And I think that that is one important lesson that we need to take as surgeons right before we cross that threshold to the OR. And great preparation is not just an important thing for yourself and for the efficiency of the operating rooms, it's very important obviously for the patient. And this tool is not only a tool that I believe is a good, or I should say great educational tool for the residents, but I think that a lot of people get educated here. And it was already mentioned that the patient is educated. I also believe very strongly that no matter how much experience you have as a surgeon, you get an education from this technique. And so I want to bring up the fact that although we've been looking at this technique with multiple modalities, that is the ability to fuse multiple modalities together, which is wonderful in and of itself, I think that there's a lot of information that could be extracted by simply using one modality. And whereas a lot of examples that we've seen have been tumors, I also feel that the information that is obtained and gained from this technology is not lost on the vascular disease, specifically aneurysms. And so what I'll do is I'll take you through these next few minutes through the case of a typical anterior communicating artery aneurysm, look at some of the benefits that this technology can provide, and then just sort of toss in a little extra dose of registration with postoperative CT and CT angiography, and let's see what we can get. And so this is a 54-year-old woman who initially presented with a Hunt S1 subarachnoid hemorrhage. CT angiography was performed as part of our routine protocol, which identified the presence of the anterior communicating artery aneurysm that you see here as being coned in on. You notice that both A1s are large, and therefore she complies as a codominant anterior communicating complex. She has a small anterior communicating artery, and as you see through the rotation, you will find the small portion of the anterior communicating artery present right beneath the aneurysm. The aneurysm itself is bilobed, or you can say it's unilobed with a very ectatic and ugly-looking bleb that points posterior, laterally, and slightly superiorly. Given conditions of the patient's status, neurological status, as well as her age, and the size and configuration of the aneurysm and the aneurysm neck, I felt that this was best approached through a surgical option. And the question becomes, what would the best surgical option be? Given the fact that you have codominant A1s, most surgeons, and this is a big discussion that always occurs, and we're not going to belabor the point, most people would just go right through the right side because that's their position of comfort. Others might say it would be best to approach this from the dome or from the left side because that would be the area that most of the aneurysm is pointing to. One of the things that you can achieve with the Dextroscope is to actually simulate your craniotomy, as has been shown here in several instances, performed in typical pterional fashion that then extends more frontally than it does more along the middle cerebral artery or temporal region. You will get exposure of the regions of interest. Here, namely, being the anterior communicating artery complex. And you can see that if you go even a little bit more anterior, and then you position the head and you keep it at the 5-degree off tilt, off neutral, you have all the exposure that you need. And when you cone in, you get an excellent view of the anatomy. You can see us now coning in a little bit and zooming up to show the relationship of the aneurysm, the ipsilateral A1, the contralateral and ipsilateral A2, and you can actually see the ACOM artery proper. Now you can see that the aneurysm is touching on the A2 segment, and that the A1 is tucked away and actually behind and not well in view from this 10-degree or 20-degree rotation. On a 5-degree rotation, you can actually see the A1 segment much better. That's perfect. So with that plan in mind, you can see that the neck is exposed, and you can look and consider what would happen if I looked at this from the other side. What if I approach this from the left side? Well, from the left side, if you do the craniotomy, and I think for the interest of time we might just crop down to it, but as you turn the head and you look more towards the left side, what you will actually come to realize is that not only is the dome of the aneurysm in your approach, or in your face as it were, but in addition, the actual bleb is right in front of you, and so most of your manipulation and dissection is going to be around a ruptured bleb, not to mention the fact that the neck is now deep to your most critical part of the anatomy. And so, again, pointing to the fact that this would most benefit from a right-sided approach. Having performed a right-sided craniotomy and clipping of the aneurysm, part of my routine is that all patients undergo CT angiography at approximately day 4 post-ictus. And so we obtained that data, and because of the excellent co-registration technology that exists, you can superimpose and co-register your CTA from post-op with pre-op. And there's a lot of interesting things that come to bear. The first thing is, number one, you can segment the aneurysm clips, which can be segmented separately. And you can see here that there are 2 clips placed. Number two, as you will see when we zoom out and go back to the craniotomy post-operatively, you can see that purple is now the post-op CT scan superimposed on the yellow pre-op CTA. You can see from the post-op CTA that the craniotomy that I made was indeed focused more on the right, and I did in fact enlarge the posterior part or the temporal portion of this craniotomy. But if you then mechanically, quote, drill away the post-op craniotomy part, and you can see that clearly on here, you will notice that upon drilling the post-operative visualized craniotomy, the line of sight, the trajectory, is overlapping. Okay? That serves a lot of, I think that gives us a lot of important information. Number one, this becomes a great teaching tool for the residents, which again has already been emphasized a couple of times. But I think this really brings it to bear. Okay? Number two, and I think this is something that is a topic for research that we really need to look at more closely, is notice that the supraclinoid internal carotid artery is incredibly well registered. The purple and the yellow are superimposed, and you see now that the segmented aneurysm clips are being removed and superimposed back on the original data. But one thing that you can focus on is the fact that the supraclinoid ICA and the pre-op and post-op are essentially perfectly registered. Notice the distal A2 segments ipsilaterally that also demonstrate excellent co-registration. The thing that I found most fascinating was that right around the area of the clip, you have a movement or a shift in your A2 segment right around the level of the ACOM complex. And I think that's actually a fascinating thing. It is not a function of artifact generated by the aneurysm clip, which is a titanium clip, because you have no loss of signal. The signal follows through all the way up, and you can see that because of the excellent color schemes that you see. There is no volume lost in this data. But what you do see is a significant shift, slightly significant shift, in the A2 segments that shows up here that would not be noticeable to the naked eye and cannot be picked up if you were to try and take your 2 CTAs and try to manually superimpose them. And so I think that that is something that is incredibly important and interesting to me, and is going to be one of the avenues of study that I will embark upon with my residents. Another avenue that we will embark upon is looking more closely at how this will apply to the planning and treatment of arteriovenous malformations and other vascular disease in the head and neck. At this point, if there are any questions, I'd be happy to field them. This is sort of what I wanted to show you. Notice that again, this is CTA data, this is not MRA data, this is one modality. It is taken 2 days apart, automatically co-registered, exquisite co-registration, proximal and distal to the aneurysm clips, and you can actually see looks like a couple of millimeter or 1 millimeter shift. The etiology of that shift is something that we'll need to discuss and explore, whether it's retraction, whether it's edema, or whether it's mechanical movement and torquing of the aneurysm clips. And more information will come forward as we study this with this protocol in the near future. Thanks for your time, folks.
Thanks very much.